Good afternoon, everyone. Welcome to this Aspergillosis patient conference. It's great to see so many people online. I'm going to hand over now to our chairs for the session, Lisa and Tom.
Thank you, Courtney. Hello, everyone. My name is Lisa McNeil, and I would like to welcome you to our first Aspergillosis patient conference today. Before I tell you a little bit about myself, I did just want to tell you about the translation app that we are using today. It's called Wordly, and it provides automated translation in over 60 languages. We've posted a link into the chat box, but there is also, I think there on the screen now, you can see there is a QR code. So when you access the app, first of all, select the language that you want from the drop-down list. And then if you click Attend, Wordly should open in a screen. You can position it alongside the webinar so that you can view both screens side by side. You can choose, I think, to either read the transcript or you can have a headset on and listen to the audio. Obviously, we know that automated translation is never perfect, particularly when we're using some medical words. So some of the words and phrases might not be quite right, but we hope that it will make this conference accessible for many people. If you do have any problems accessing the app, you can email info@europeanlung.org, and a member of the European Lung Foundation team should be able to help you out. Okay, so now I'll tell you a little bit about myself. As I said before, my name is Lisa McNeil. I am a member of the ELF Aspergillosis Patient Advisory Group. I am a patient myself. I have bronchiectasis and Aspergillus bronchitis. And I'm also co-founder and chair of the charity, the Aspergillosis Trust. My hope for today is that this webinar brings clarity, connection and comfort. I want people to feel better informed, less alone, and more empowered to navigate this complex disease. I'm now going to hand over to my co-chair for the day, Tom, to introduce himself.
Thank you very much, Lisa. My name is Tom Birmingham. I live in Wexford in Southeast Ireland, so I'm beaming into you from there today. After 3 years of recurrent chest infections and all of that type of respiratory issues, I was diagnosed with what my consultant considers a complex mix of severe adult onset asthma, bronchiectasis, and aspergillosis. So it is quite complex. I was very happy to find a support group because in Ireland, aspergillosis is largely unheard of. So I was very happy to find a support group in the NAC in Manchester a couple of years ago. And they've been a huge support because living with a chronic disease like aspergillosis can be overwhelming, and indeed it can be a very lonely place when you have something that very few people have heard of or understand. Earlier this year, I was lucky enough to join the patient advisory group with the European Lung Foundation. I met some very good friends, including Lisa here, who's co-chairing with me today. So these are a lot of people that have become good friends and good support to me, and I think that's very important. I'm always keen to learn new things about this disease because a lot of it is about self-help, but a lot of it is also about knowing where to find the correct information. And in both the NAC and the European Lung Foundation, that's where you'll find it. And also obviously in the Aspergillosis Trust as well. So I'm really looking forward to hearing from today's speakers. We've a very good lineup, and I'm really looking forward to learning again from them. And I am sure that the many listeners that we have from all over the world will do likewise. Just before we go any further, then, to ensure that the conference runs smoothly, there's a bit of housekeeping that I have to remind you of. This is a webinar, so attendees can see the speakers, but we cannot see you. everyone is on mute. We can't hear you, but you can participate in the chat and the Q&A that's on whatever device you're watching this on, and we really encourage you to do that. If you have specific questions for the speakers, we encourage you to write them in the Q&A rather than in the chat. We'll try to have as many questions as possible answered during the panel discussion that will follow the speakers. If there's some unanswered questions that we don't reach on, we will try to get answers from the speakers, and those answers will be put up on the European Lung Foundation website in the coming weeks, so you can keep an eye on that. Please bear in mind that we cannot answer questions that are very specific to your own individual case, much as you might like to. I know that, and I know that from experience for myself over the past few years, but you have to understand this has to be generalized. We will have 2 polls that we'll ask you to participate in, and we'd encourage you to do so. If you do use social media, we'd ask you to tag the European Lung Foundation and the National Aspergillosis Centre and the Aspergillosis Trust, because raising awareness of this disease is primarily what today is all about. As I said earlier, it's a largely unknown disease in many parts of the world. So the more use of social media, the better to get the message out there. The conference is being recorded. The talks will all be available on the Lung Foundation website in the next 2 to 3 weeks, I'm told. And a link to these will be sent by email to all attendees. So I understand there will be people who have registered who for one reason or another are unable to join with us today. So that will be there for you. So I'll hand back to Lisa now.
Thank you, Tom. So today's conference is organised as a collaboration between the European Lung Foundation, the Aspergillosis Trust and the National Aspergillosis Centre. You will find out a little bit more about all these organisations later on today, and how you can get involved during Graham's talk. We especially would like to thank the members of the ELF Patient Advisory Group. They are the organisers of this event, and it wouldn't have been possible without their dedication and enthusiasm. And all of the speakers who you will be hearing from today are giving up their time on a Saturday afternoon to share their knowledge with us for free. So I would just really like to say thank you so much for doing that for us. We really do appreciate it. I'll hand back to Tom, and he can give you a little bit more information about the outline of today.
Thanks, Lisa. So yeah, just we're going to have 4 talks. There'll be approximately 15 minutes duration. That's what we've told the speakers to try and keep it to that. These will be followed by a panel discussion and a question and answer session, which I expect that the audience will find really useful. After this, we'll have a final talk from Graham Atherton. Graham is from the National Aspergillosis Centre in Manchester. We aim to finish this conference in approximately 2 hours. That'll be around 4 p.m. Central European time or 3 p.m. UK and Irish. I have to throw in the Irish piece. Talks will cover a wide range of issues. They'll include an overview of aspergillosis, the symptoms, the diagnosis and treatments, and very importantly, we'll hear the patient's experience of living with aspergillosis. And I really think that will be very interesting for people. Again, just to remind you, be sure to write any questions in the Q&A box, not in the chat. But remember, as I said earlier, try not to be specific to your own individual case. Again, if there are questions in the Q&A that you consider a priority, there's an option there to use the thumbs up icon for those of you who are tech savvy. This will flag them for our attention, and maybe, I suppose, it'll also help us to avoid duplication. So, okay, back to you, Lisa.
Okay, thank you, Tom. I think I would just say as well about the Q&A, I will be keeping my eye on that. So if you are interested, then please put a thumbs up next to a question, and I will make sure that we try to pick those out. Okay, so firstly, can we'd like to run this poll. We want to ask you to please rate your current knowledge about aspergillosis. So the poll is there now. we can vote as well. So the hosts and the panelists. So please vote now if you wouldn't mind. Okay, so we have the results. So we have, well, we're kind of quite spread, a lot of people around 5 and 6. And then we've got some people at 8 there, 19% of people have quite a bit of knowledge. So yeah, great. Thank you very much for that.
Okay, thanks, Lisa. So now, just to get on with the show, so to speak, it gives me great pleasure to introduce our first speaker of the day. That's Dr. Oksana Munteanu. And Oksana is an associate professor in the Department of Pneumology and Allergology at the State University of Medicine and Pharmacy in the Republic of Moldova. Dr. Oksana will give a broad overview of aspergillosis and the different forms of that. So over to you, Dr. Oksana.
Thank you, Tom, for your kind introduction. Hello, everyone. Good afternoon. I'm really excited to speak to so many people who want to share their knowledges about aspergillosis and about the problems that have the patients with aspergillosis. Please let me share my screen. Can you confirm that everything is okay, please? Can you see my slides?
Yes, Oksana, we can see your slides.
Okay, I have no conflicts of interest related to this presentation, and in today's presentation, I will start with an overview about aspergillosis mold and what it is, where come it from. After that, we'll continue with the types of aspergillosis, and we'll discuss a little bit about who is at risk and why. It's quite interesting that the name of the group of aspergillosis comes from the Latin word aspergere, which means to scatter. What's mean aspergillosis? This was a name given to the group of medical condition caused by the fungus Aspergillus. Aspergillus was first described in 1729 by the Italian botanist and mycologist Pierre Micheli in his work Nova Plantarum Genera. Micheli chose the name Aspergillus when he looked at it under the microscope, and this structure looked like a holy water sprinkler used in church, and according to this, he chose this name. It's sorry. Aspergillus is classified as a filamentous fungus and belongs to a group with fungi called Ascomycota, which produce spore. Aspergillus reproduces by extended filamentous structure called hyphae. I hope you can see my pointer. And when certain conditions are met, this means enough oxygen, enough warmth, enough water, Aspergillus forms specialized structure that we call conidiophore, and after that giving rise to conidia. Conidia are type of asexually produced spore, and the color of many large colonies is attributed to the pigmentation of this conidia. Sorry. I have some. You can see different colonies on different color, and this color due to this pigmentation. The surface of conidia is highly hydrophobe and allowing it to float and in the air long periods without being surrounded by water molecules. Aspergillosis is one of the rare disease, but not so rare as we think. Aspergillus species are common fungi widespread in the nature, in soil, on decaying vegetation, in the air, and in water supplies, and in the compost pile. The main route of infection in aspergillosis is airborne via inhalation of these conidia or these spores, and lungs are the most common site of infections. Humans are estimated to inhale daily according 100 or 1000 aspergillus conidia each day, and some of them can reach even the alveoli in the lungs due to their very small size, 2 to 3 micrometer. More than 350 species of Aspergillus are found in nature, out of which only 20 species can cause human disease. Out of these 20, only 3 will cause the most frequent disease, and these are Aspergillus fumigatus. This type of fungi is responsible for more than 65% of the disease. The next one is Aspergillus flavus and Aspergillus niger. Are fungal infection frequent in respiratory tract? It's a good question, and the answer is more than we could think probably. More than 300 million people worldwide are affected by a serious fungal infection, and many of these have coexisting conditions, such like cancer, AIDS, TB, COPD, or asthma. Fungal disease, especially aspergillosis, have a major global impact. Each year, around 6.5 million people develop severe fungal infections, and nearly 4 million die. It's bad news, but as well we can observe that a big number of patients have even invasive form of aspergillosis, and these are patients with severe immunosuppression, with different hematological disorders, with severe form of COPD, the patients that need treatment in intensive care unit, and the patients with lung cancer. As well, we have a big number of chronic pulmonary aspergillosis patients, more than 1.8 million population, and it is very connected with the, as we can see in this slide, that represent the rates per 100,000 population. The prevalence of chronic pulmonary aspergillosis, and is highly different, and it's connected with the area where we have an increased number of patients with TB, and the connections between TB and aspergillosis is quite relevant. As well, according to the data that WHO present as estimation of a real number of chronic pulmonary aspergillosis patients, we have an increased number compared to 2007 and 2020. Pulmonary aspergillosis can take different forms depending on patient's immune status. As I said previously, daily we can inhale more than 1,000 spore, but if our immunity is in a good condition, we will have no sequelae. And in cases when we have an hyperreactivity immune system, especially patients with asthma or some kinds of atopy. We can have patients with allergic bronchopulmonary aspergillosis. And in cases when we have a severe immunocompromised host, we can have a case with invasive pulmonary aspergillosis. These are the main types of aspergillosis, and here we have three main groups. Allergic bronchopulmonary aspergillosis. This is a hyperresponsivity reaction to aspergillus colonizing the airways, and allergy to aspergillus, not an infection. Invasive aspergillosis, this is a severe form of infection, and due to the fact that we have severe immunosuppression, the fungi will spread in other organs as well, and this form of aspergillosis cause high morbidity and mortality. The third group are chronic pulmonary aspergillosis, and in these cases we can have a small decrease in immune status, but usually these patients have some problems with their lung. This means some cavities, bronchiectasis, or severe emphysema. And in cases when we have no meet criteria for invasive aspergillosis, allergic bronchopulmonary aspergillosis, or chronic pulmonary aspergillosis, but we have a persistent localized infection on the surface of the bronchi, we call this disease Aspergillus bronchitis. Which are the defense mechanisms against Aspergillus fumigatus that help us not to have a disease? Usually, when the conidia are inhaled daily by people, respiratory epithelium and natural immune system act immediately, and epithelial cells will detect the spores and release inflammatory signals that attract the immune cells. Macrophage will ingest and neutralize the spore, while neutrophils destroy germinating hyphae through oxidative burst and net formation. If this first line defense fails, the spore may germinate into hyphae and will lead to invasive aspergillosis, especially if we have an immunocompromised patient. Which are these immunocompromised status? These are patients with cancer treatment, patients that are in severe condition that need hospitalization in intensive care unit, patients with solid organ transplantation and stem cell recipients, other immunosuppressive conditions like HIV or immunosuppressive drugs, severe influenza, and severe COVID-19. In cases when we have hypersensitivity reactions, and these are patients with asthma and cystic fibrosis, we will have another response from our immune system. In these cases, Aspergillus act as an airway allergen rather than an invasive pathogen. Repeated exposure to Aspergillus antigen will activate the lymphocyte CD4 Th2 type, and this will activate the interleukin 13, 5, and 4, but will lead to increased secretion of immunoglobulin E. As well, we can have an increased eosinophils inflammation that will result in mucus plugging and sometimes in bronchiectasis, but it is the hallmark of ABPA or allergic bronchopulmonary aspergillosis. As we can see in this CT, we have huge bronchiectasis, central bronchiectasis, and they are filled with mucus. When we speak about chronic pulmonary aspergillosis, we in these cases have lung abnormalities like cavities, bronchiectasis, or a severe emphysema that provide places where the fungus can survive and grow. In these settings, the local immune system will not fully respond and is not possible to be eradicated, and this will lead to chronic colonization and sometimes with the appearance of fungal balls or aspergilloma. In the last row, you can see one of my patients, a 56 years patient that was treated for TB 5 years ago and presented in emergency department with severe hemoptysis according 5 milliliters of blood. And on CT, if on chest X-ray there are not so many changes on chest X-ray, on CT we can see the bronchiectasis, and it was a surprise. During the bronchoscopy we can identify the fungus ball inside of the bronchi. There are several subtypes of chronic pulmonary aspergillosis, and some of them can even transform each other. The most simple form is Aspergillus nodule, but it is quite difficult to diagnose. Especially for this, we need biopsy to confirm that inside of these nodules we have Aspergillus. More typical picture we have for simple aspergilloma. This is the most easy form, because here we can treat the patient with surgery and antifungal drugs, and this is the form that for which we have not so many challenges during the diagnosis. The other forms, chronic cavitary pulmonary aspergillosis and chronic necrotizing pulmonary aspergillosis, in cases when we have no fungus ball inside, sometimes it's quite difficult to differentiate with reactivation of TB, especially in cases when patients have TB previously. And as a home message, Aspergillus is a common mold found everywhere in soil, air, and decaying plants. Most people breathe in its spore daily without any problems because we have a very good immune system. Aspergillosis is not contagious. It affects mainly those whose lungs are already weakened by asthma, bronchiectasis, emphysema, fibrosis, or cavity, or those immune system is low after chemotherapy, transplant, or long time administration of corticosteroids. There are three main types of pulmonary aspergillosis: ABPA, or allergic bronchopulmonary aspergillosis. The immune system overreacts to the fungus. Chronic pulmonary aspergillosis, the fungus grows slowly in pre-existing lung damage, and invasive aspergillosis, a severe infection spreading in the body of immunocompromised patients. Thank you for your attention.
Thank you so much, Oksana. That was really, really interesting. I was particularly scared, really, by some of those figures, particularly, the fatalities of patients. The sheer volume of people that are losing their life to fungal infections is really quite scary. But yes, thank you very much. If anybody does have any questions for Oksana, please remember to put them in the Q&A session. Okay, I would like to introduce the next speaker that we have today, Dr. Mattia Negro. Mattia is a PhD student at the Humanities University and a respiratory unit physician in the IRCCS Humanitas Research Hospital in Italy. And he will be talking to us today about the signs, symptoms, and the diagnosis of aspergillosis. So thank you very much, Mattia, and over to you.
Thank you very much, Lisa, for the kind introduction, and thank you to all the organizers for the invitation. I'm really happy to be here and to talk about this often under-recognized disease. So I will share my screen in a sec. Okay. I guess can you confirm you can see my screen, right?
We can, Mattia, yeah.
Yes. Okay. Wonderful. So basically, the point where I would like to start is that in continuous with what Oksana just said, aspergillosis is a term that we use to describe different several diseases that are in continuity one with the other. So we've talked about ABPA, we've talked about aspergilloma, chronic pulmonary aspergillosis, and invasive aspergillosis. Actually, this kind of disease labels that we apply to people suffering from this disease are actually helpful to understand what's beneath them, so the biology, and to understand how active is the immune system of these people, but actually do not describe pretty well all the complexity of this condition. But I would like to start from the ABPA first. So basically, when we talked about the ABPA, as Oksana mentioned, we're talking about an allergic reaction in comparison to a fungi, usually Aspergillus fumigatus, but this is also something that could happen to other species of Aspergillus. Basically, what happens is that in the airways of the people suffering from ABPA, there's a very thick mucus that is the evolution of the uncontrolled inflammation, a type of inflammation that we call the eosinophilic inflammation, so an inflammation that resembles the one of asthma, that actually can generate this very thick mucus and sometimes may even delay the bronchi and generate what we call bronchiectasis, and sometimes generate what we call mucus plug, so a very thick mucus that is stuck inside the airways. When we talk about ABPA, it's really crucial that we focus on what we got as a doctors to diagnose this kind of Aspergillus-related disease. So basically, the diagnosis of ABPA is usually made through the evidence of certain radiological features that we highlight on the chest CT. So I got some chest CT images right now. This is the lung. These are the two lungs. And basically what you can see over here where the arrow is pointing is that these airways appear to be dilated. Okay, this is what we call bronchiectasis, so an ectasis of the bronchi. This is one of the main radiological appearance, one of the main radiological features of a BPA. When these features are associated with certain other features, like for instance, these small nodules that you see over here, that actually resemble a tree in bud. This is the so-called tree in bud appearance. This actually represents mucus that is stuck in the very distal airways, in the very small airways of people suffering from this kind of disease. But some people actually have more evident forms in terms of radiology. For instance, some people might suffer from very thick mucus that is stuck inside the central airways, like you can see over here. These white opacities are actually very dense secretions that when removed actually resembles the forms of the bronchi, and sometimes these mucus is so thick that can even lead to a collapse of a part of a lung, or in certain cases of a whole lung. So you can understand that these are the signs typical of this form of ABPA, but this does not usually, sometimes does not correlate with the severity of symptoms that a patient might suffer from. So when we talk about allergic bronchopulmonary aspergillosis, we should know that some of the symptoms that a person might suffer from are respiratory, and some of them are systemic. Among the respiratory symptoms, the most common ones are the cough, the dense sputum production, the wheezing, the dyspnea, and I'll go through this in a second, the exacerbation of asthma, and sometimes hemoptysis. While systemic symptoms are usually fever, most commonly is a low-grade fever, malaise or fatigue, and sometimes anorexia. I will go through a few of these very, very specific symptoms just to be sure that we know how to describe these symptoms when we talk to each other, because it's sometimes important to even have an agreement on some of these terms. So I will go through cough. Cough is something that I'm pretty sure everybody has some experience of. So cough is what we describe as a forced expiration that is by will or spontaneous. But actually, as a doctor, we're a lot interested in the features of the cough. So there are some people actually suffer from paroxysmal cough. Some people suffer from continuous cough, so cough that is present in all moments of the day. Some people suffer from dry cough, so cough with no secretion. Some people suffer from productive cough, so they expectorate quite a lot. sometimes it's important to describe the context of onset of cough because this might guide us through the diagnosis. For instance, a cough that is usually caused by meals is something that could resemble other conditions, for instance, gastroesophageal reflux. And the association with other symptoms is important to us, even to make us think about certain diseases like ABPA. The etiology of cough can be quite variable, so it's actually pretty can be sometimes pretty challenging to diagnose ABPA just based on the cough. But actually, the more important stuff I would like to focus here is that cough is not something. It's not an easy process. So every time a person coughs, there is a very complex mechanism that starts from an irritation phase in most cases, and then there's an inspiration phase in which people actually increase the volume of air inside their lung. Then there's a compression, so a phase in which the pressure inside the thorax is increased, and after that there's an expulsive phase. This is important because some people that suffer from certain disease might have a defect in some of these physiopathological actions. So sometimes cough can be invalid, so might not lead to a proper expectoration, especially in the case of a BPA, in which the resistances of this very thick mucus is sometimes hard to overcome. And the other important stuff is the sputum production. I'm pretty sure that everybody knows what sputum is. So it's the drainage of respiratory secretions through the airways. As a doctor, I'm a lot interested about the appearance of the sputum of my patients. This is the Murray scale that you can see over here. So it's a scale in 8 degrees of colors that actually is really important because it's associated very, very tightly with the amount of inflammation and the amount of neutrophilic inflammation, especially, and the load of bacteria that we find inside the airways. So it's actually something that could be really helpful from my side. I'm a lot interested about the quantity of the sputum. It's difficult sometimes to quantify sputum production, but I usually talk to my patient and ask them to describe how much sputum they got in an average day based on very common measures, for instance, a teaspoon, a tablespoon, half a cup, or a teacup, or a coffee cup, or whatever. And the frequency is also very important. And the last symptoms that I would like to focus on about ABPA is the dyspnea. So what we call dyspnea is a subjective sensation of breathing difficulty that is actually very complex to describe. So basically, dyspnea is a symptom. So it's something that patients report to us. It's not something that we directly experience, but it's something that I rely very much on because it's really important from my side to describe the burden of a symptom of a given disease, including a BPA, in the person I'm facing in a given moment. So when I'm interested about dyspnea, I'm a lot interested about the mode of onset. So if it's acute or it's a gradual or chronic dyspnea. If there are certain exercise or certain triggers that might go the dyspnea even worse, if there is an association with other symptoms, and more importantly, I would like to quantify the dyspnea. So there are several scales that we commonly use, like the Modified Medical Research Council scale or the Borg scale that we sometimes use in the clinical practice to try to quantify the dyspnea that my patient actually suffer from. And then there's another aspect. So we know that most people with a BPA have got bronchiectasis, and this is our latest study in which we analyze the symptoms of bronchiectasis in a large cohort with 10 centers from 5 different European and Asiatic countries. And what we found is that there are lots of symptoms that are actually not very well described by current definition. For instance, lots of people suffer from fatigue, suffer from sputum hypersecretion, suffer from weight loss, suffer from night sweats, suffer from dyspnea or nocturnal respiratory symptoms. And this is really important in my view because when we have to think about the symptoms of a person with bronchiectasis or a person with a BPA is suffering from, we should think outside of the box and think of all the symptoms that have a weight on that have a burden on their quality of life. So these symptoms actually change in the intensity and in the frequency over time. And in bronchiectasis people, we've seen that people with the more classical symptoms are represented by cough, sputum production, and sputum purulence. You can see this overlap over here in in the graph, but there are lots of other symptoms that form this galaxy over here that actually define probably a different phenotype of patients, so a different group of patients that is actually not described very well by the classical symptoms. Moving on to chronic pulmonary aspergillosis. So Oksana described the definition pretty well. I will try to focus on the radiological science and on the symptoms of this. Basically, chronic pulmonary aspergillosis is a form of aspergillus that is usually affects immunocompetent patients with a predisposing pulmonary conditions. The most common are TB or COPD or mycobacterial infection or sarcoidosis or bronchiectasis or the pneumothorax or whatever. There are different forms of a CPA, sorry, that Oksana described in a while. And it's actually a different disease from ABPA because ABPA is more like an allergic reaction to Aspergillus fumigatus with an inflammatory response similar to the one that you see in asthma. Usually in ABPA, you do not need to isolate Aspergillus fumigatus or any other Aspergillus in the secretions of people suffering from this disease to make a diagnosis. And it's usually characterized by mucus plugs and acute exacerbation of asthma, while CPA is usually a condition in which there's an accumulation of the hyphae of Aspergillus fumigatus or other Aspergilli in the airways of these patients that actually are chronically exposed to the fungi. And sometimes you need to demonstrate, according to the current definition, that Aspergillus fumigatus or other Aspergilli are there in the airways with a sputum assessment or bronchoscopy or biopsy. People might be asymptomatic. It's a chronic disease, so people might be asymptomatic for a course of time, but after that they might develop some symptoms. And the most important one in terms of frequency and in terms of burden in the daily activities of patient, in my own experience with talking with my own patient, is hemoptysis. So basically, hemoptysis is the words that we use to describe the expectoration of blood. The first thing I ask to my patient when they report they got hemoptysis is are you really sure this is hemoptysis? So basically, I'm interested in defining hemoptysis agree on a definition of hemoptysis with my patients. Hemoptysis means that the blood comes from the lungs, so it's usually coughing up blood. It's not finding blood on the napkin. So it's usually important to differentiate hemoptysis from ENT bleeding, so bleeding of the mouth or the nose or the ear. It's important to distinguish that from gingival bleeding. It is a very common sign in our daily clinical practice, and it's important to differentiate from hematemesis, that is the vomit of blood. Actually, hemoptysis is a very important symptom, and sometimes make me think about doing different treatments because it's something that is usually really important as a burden on quality of life. And the most important stuff is that when I talk to my patient, I actually agree with them a self-management plan for the hemoptysis. So sorry for the Italian. This is the true sentences that I use with my patients when we have a visit together. So this is in the visit, in the letter that I give them while I do an outpatient clinic visit. And basically I said to them, well, I hope you're fine, but in case you got some hemoptysis, this is what you should do. So it's really important that you know how to manage this. Come to the hospital if needed. Take some drugs. We usually prescribe tranexamic acid as a drug, but it's really important that you know how to manage this properly. So the management plan of this patient is actually important in this view. As mentioned before, chronic pulmonary aspergillosis is an umbrella term, so there are lots of different entities over there. We got the Aspergillus nodules, we got the Aspergilloma, we got the chronic cavitary pulmonary aspergillosis, we got the chronic fibrosing pulmonary aspergillosis, and the subacute invasive pulmonary aspergillosis. These different forms have different radiological features, so as a doctor, I'm interested in looking at all these features through the chest CT. These are the nodules that we discussed even before, so these whitish opacities over there. These are nodules. Sometimes, as Oksana mentioned, a biopsy is needed to confirm aspergillosis inside these nodules. while these are cavities. So these are large cavities in which you see there's lots of air inside the lung. And sometimes these cavities are actually populated by IFE. So this is what we call a fungus ball. So a cavity with some fungal mass inside of them. And what can help us in diagnosis this sometimes is actually make a scan with the patient upside down, just to be sure that the density of the material over there is actually compatible with fungal infections. Usually, this kind of mass is a very dense and follows the gravity. So basically, turning the patient upside down in the chest CT could help us in defining the disease Aspergillus and actually start a treatment just over there. And there are some cases in which the cavities might be even larger and sometimes might be even cause fibrosis and sometimes might even lead to a collapse of a part of the lung. So these are the radiological features that I rely on mostly to identify patient with CPA. The diagnosis of CPA is actually based on compatible radiological features, as I showed you before, the evidence of Aspergillus infection or the evidence of an immunological response against Aspergillus through the analysis of respiratory secretions or blood test, and the exclusion of other possible causes, for instance, mycobacteria, tuberculosis, pseudomonas, MRSA, and whatever. Usually, CPA is something that is defined over a course of at least 3 months' time. So there's a stability over 3 months in the radiological features, for instance. But sometimes it's in some cases it can be a more aggressive disease, and we will need to start a treatment just after that. Just to conclude on, the last form is the invasive aspergillosis. So basically, this is the most acute and severe form of aspergillosis that usually affects severely immunodepressed patients with low defenses against these molds. It's an acute disease, sometimes can be life-threatening. The main manifestation are cough, dyspnea, and fever. Sometimes we got some tests, for instance, the serum galactomannan or the pulmonary biopsy can help in the diagnosis and often requires immediate treatment with antifungals. The radiological features of invasive aspergillosis are actually represented by these nodules that are similar to the one that I showed you before, but that sometimes might actually increase in size and have this aspect that we call halo sign. So there's like an halo over here that is usually can be the sign of invasion of the mold over the tissue of the person that is suffering from this disease. So basically, to conclude, these are the main challenges that highlighted in the management of people suffering from this condition. So there's basically no single test that can help in the diagnosis of Aspergillus on its own, and then can differentiate between the different diseases related to Aspergillus. But usually we need to rely on a set of tests: radiology, sputum examination, or bronchoscopy, or respiratory secretion examination, and sometimes serology. The other challenge is represented by the fact that immunocompetency is not easy to define. So there are some patients, some people that are clearly immunocompromised because they suffer from hematological diseases or other condition, and that's easy. But lots of people have an immune system that is not working 100%, but maybe 80% or 60% or 40% of their expected value. The other important challenge is represented by the fact that different Aspergillus-related diseases, the 3 main boxes that I showed you before, might overlap. So there are lots of people that suffer from a disease that is actually it started as an IBPA, then moved to a CPA, or the other way around. So it's actually pretty complex to define and to treat these people. And the management of the associated condition and the comorbidities can improve the outcomes if it's managed by expert doctors that actually work in a multidisciplinary team to be sure that everything is treated properly. And thank you very much for the attention, and I'm all here for your questions.
Thank you very much, Mattia. That was a really thorough and an interesting overview of the symptoms and the diagnosis of aspergillosis. And I think for me, it certainly went some way towards explaining why diagnosis of whichever format of aspergillosis is a lengthy process. And I think you use the word complex quite a bit. And for me, that certainly sums it up. On a personal basis, I'm told of that word almost every time I meet a doctor. So thank you very much. I'm sure there'll be questions for you in the panel discussion later on. So moving along now, we're very fortunate to be joined today by Professor Darius Armstrong James. Darius is a professor of infectious diseases and medical mycology in the Department of Microbiology at the Imperial College in London. Darius is also an honorary consultant physician in infectious diseases and medical mycology at Imperial College Healthcare and the Royal Brompton and Harefield Hospitals at Guy's and St Thomas in the UK. Today, Darius will give us an overview of the treatment and management of aspergillosis, and we're delighted to have you. Thank you. Over to you, Darius.
Can you hear me?
I can hear you now, Darius. Yeah.
Great. Yeah. Thanks very much for the kind words, Tom. And thanks to the previous two speakers for a really beautiful introduction to aspergillosis. Really nice to hear. Can you see my slides?
Yes, we can see you now.
Great. So they're in full screen mode, basically.
That's okay. Yeah.
Great.
Perfect.
Brilliant. Thank you. So I'm going to speak about the treatment and management of aspergillosis. So first, I'm going to give an overview of antifungal medication. So I think this is a really nice way to start when we think about the different treatments we give for fungal infections, including aspergillosis. As you can see on this slide, what we have here is basically a cell. So this is one of the cells of Aspergillus, very similar to the cells that we have as humans inside our bodies. However, there are some key differences here, and they are that our cell membranes are actually made up of cholesterol, believe it or not, which people often say is bad for you, but actually is also an essential nutrient. However, in fungi, there's this key difference that they actually have a cell membrane that's made up of ergosterol, which is the fungal equivalent of cholesterol. It also happens to be vitamin D2, which is quite interesting in itself. And this ergosterol is made by beta-1,3-glucan synthase, which is the target of the echinocandins. So that's one of the targets. And then, unlike humans, we don't have something called a cell wall. That's only present in fungi and plants. And this cell wall basically protects the organisms because they're often single cell. And it has a number of different things in it. Chitin, which is also part of the skeleton of insects and very, very hard. And then these different sugars called glucans. And again, these are also targets of antifungals. So ergosterol and glucan are all targeted by different antifungals. And when we look at these different components, as I said, fungi use ergosterol rather than cholesterol, which is important. There are also some drugs, although not very often used, that target DNA synthesis, and we don't have a cell wall. So this could be a good target because if you give a drug that targets the cell wall, it's unlikely to be toxic to humans. So what are the different drugs that we use and which areas do they target? So there's this group called the polyenes, as you can see here. And amongst these, you have amphotericin B and nystatin. Nystatin is only really used to treat oral thrush, but amphotericin B is used in aspergillosis, either in the invasive form, as I'll come on to, or as an inhaled drug, sometimes for airway-based aspergillus. And this basically targets the cell membrane, so the ergosterol in the cell membrane. And actually, what the polyenes do is they directly disrupt the cell membrane, and this makes the cell explode. So this is a very good way of killing the fungus, and these drugs tend to kill it completely. And then we have the azoles. So these azole antifungals are basically also targeting ergosterol in the cell membrane here. And there's been a whole number of them, and probably most people who know about Aspergillus are receiving either itraconazole, voriconazole, or posaconazole. But there are lots of other ones that are also used for various different fungal infections. And these drugs also target this cell membrane made up of ergosterol. However, they aren't quite as lethal as the polyenes, but they do have this very useful trait that they can be taken as tablets, which amphotericin B can't. And then the other drug that we use sometimes is flucytosine. This is rarely used for Aspergillus, and it's interesting, the clinical data, or at least the in vitro data, so that the test tube-based data doesn't really support it, but there is some interesting data to support its use in particular settings in people with aspergillosis. And then finally, the echinocandins, which we mentioned earlier, these target this beta-1,3-glucan synthase. This makes the beta-glucan in the cell wall. And this is present in Aspergillus, but not in the same level that it's present in Candida. So these drugs are really, really good for treating Candida because they attack something that's very prominent in the cell wall. In Aspergillus, they do have some activity, which we'll come on to, but they're probably not as strong as the amphotericin B-based treatments or the azoles for treating aspergillosis. So next, we're going to compare the treatment of invasive versus chronic and allergic forms of aspergillosis. So when we consider the invasive form of aspergillosis, then treatment is actually between 6 and 12 weeks of antifungal therapy if you've got a lung infection, which is typically what people have. However, if you've got a bone or brain infection, this might be actually much longer, 3 months, possibly 6 months, or even a year, or indefinitely. And when we compare this to treatments for bacterial or viral infection, this seems like a very long time. And what's important there is that we may have to deal with different toxicities that build up with those long-term usages. The azole options are basically voriconazole, posaconazole, and isavuconazole. And then amphotericin B, historically we would use liposomal amphotericin B, which we called ambisome. But more recently, a off-patent version, Telemed, has become available in the UK, which is about half the price. So the NHS has actually moved to this new Telemed, which we're getting used to. And then, as I mentioned earlier, the echinocandins like caspofungin, micafungin, inidulafungin, and resifungin, they have some activity in aspergillosis, but the trials that they did looking at them in the context of invasive aspergillosis showed that they really weren't as good as either the azoles or amphotericin B. So we occasionally use them when we don't have other options, or we might use them in combination if we think someone's got a resistant infection. And then the additional measures we might take for patients on immunosuppression, we would try to reduce these down as much as possible so that the patient's immune system can help to try to fight the fungal infection. And this is really critical for people who are taking corticosteroids or have T-cell or neutrophil suppression. So particularly in those instances, we'd be keen to try to modulate that. And there is this broader aspect of what we call immunotherapies. These are treatments that try to boost the immune system or sometimes turn it off. There is not a huge amount of clinical trial data, but it's quite logical if someone's got a weakened immune system to try to boost the immune system. And typically we would use something like interferon gamma, which boosts macrophage function, or GCSF, which tries to increase the amount of neutrophils in the blood and therefore the lung. So those are other options that we would consider. And then coming on to chronic pulmonary aspergillosis, it's important to appreciate that we don't always treat, because sometimes fungus can be sitting inactive in the lung, for instance, in a aspergilloma where it's not eating the lung, it's just sitting within a cavity. And we try to define this based on what's happening with the radiology in terms of the scans. And the other really critical feature is, as Mathieu discussed earlier, is around the symptoms of the patient. So if you haven't got many symptoms, we'd be less inclined to treat you. But if there is evidence of either activity, looking at the blood tests, the scans, and the patient's symptoms, then the standard treatment has always been itraconazole. Some centres also use voriconazole as a first line or the initial treatment they use. We personally don't like it in the Brompton because we know that long-term usage can sometimes cause nerve damage and can risk people to sun-related skin cancers, although not the serious ones. And so we normally would move to posaconazole if itraconazole doesn't work. And recently there's another azole called isavuconazole, which is available. This drug is really useful because whilst it's expensive, it has almost no interactions with other drugs and it's much better tolerated. So where we get stuck, we will consider using isavuconazole. And then if you're unwell, then sometimes we add an echinocandin, like caspofungin, on top of the azole to give an additional boost to the therapy. We also sometimes have to give an echinocandin where you can't take an azole because of various reasons, or where people are resistant to the azole, which does happen quite often in chronic pulmonary aspergillosis and needs to be looked out for. And liposomal amphotericin B, i.e. Telemed or Ambisome, is also an option, but it's only IV, so you have to come in for an injections, or well, it'll be difficult to give them at home because they're quite toxic, but you would probably have to come to the hospital for injections for that, which is, of course, difficult. And then the final thing is that if you're coughing up blood or having hemoptysis, then either sticking a tube down using radiology and keyhole surgery to try and block off the artery that's bleeding, or actually, if it's really severe or can't be dealt with otherwise, then resecting the part of lung that's breathing is also that's bleeding is also a possibility. And we also use surgery for very localized disease, in particular, increasingly where there's drug resistance, because that can be curative, where otherwise it might be difficult to cure the person. Moving on to ABPA, like CPA, we don't always treat people, and this really depends on whether or not patients are having symptoms associated with ABPA, and activity may lead to a number of different things, which Mattia discussed earlier, like worse asthma, mucus plugging, or even lung collapse. And what's really important with this condition is before we go into giving heavy treatments, that the inhalers for asthma are really maximized to give the optimal inhaled control before using tablets. And it's also really important to recognize there are two phases of ABPA that are targeted. So there's either these acute flares that people have where they suddenly worsen, or where people are having lots of relapses and we then need to give them maintenance therapy to prevent flares happening. And historically, the treatment of flares has been corticosteroids or prednisolone, and recent studies have also shown that itraconazole can be effective. And we also use other triazoles. And then historically, where needed, corticosteroids were used for the maintenance. However, we now increasingly use drugs called immunotherapies, which are biologics. And they are, where they are not effective or tolerated, then we would use antifungals. And we're really moving strongly away over the last 2 or 3 years from maintenance prednisolone, because it's very bad for you. So this is just a nice diagram showing you the different kind of symptoms that people can have and where those might lead you to think in terms of the treatment of that person. So if they're having basically problems with breathing, then you might worry about the asthma. Fevers and rising blood tests like CRP, you might think about bacterial infection. Infiltrates in the radiology that we saw earlier, mucus plugging, or rising antifungal serology, then we might think about treating the ABPA. And then, of course, people can have viral infections as well, and some of those, like COVID, could be treated using antivirals. And I think this slide was also shown earlier. So this is really just a schematic here of your lung with the lining of the lung here, or epithelium, and then what's happening both on the surface and below, showing you that the antifungals basically killing the fungus in the airway, whereas down here, some of these biologic treatments are targeting different types of immune responses, in particular something called a T2 immune response, which is an allergic immune response, as we discussed earlier. And this is basically some of the data that we recently published from the Brompton. So here you can see, looking at these different biologics, in particular the anti-IL-5 biologics like bemralizumab and mepolizumab, and also the anti-IgE biologic omalizumab, that basically the eosinophil targeting drugs, they do seem to reduce the number of flares or exacerbations that patients have. And they probably have some effects in terms of symptom scores, less so in terms of IgE and respiratory airway function. So in terms of monitoring of treatment and side effects, there are two aspects here. We want to know that the treatment is therapeutic, and we need to know when to stop, and we need to make sure that there are no bad side effects or drug interactions. So when is it working? When do we stop? We routinely measure the levels of triazoles. We know that there's good range in the blood that will predict whether or not someone will have a good response. And whilst there are standard durations of treatment, we will often assess the symptoms, the blood tests, and the scans to know when the treatment has fully worked. And this is a broad principle across all these different forms of aspergillosis. And then in addition, we want to monitor for drug interactions and side effects, which typically can affect the skin, heart, liver, and kidneys. There is also an issue where amphotericin B can cause blood and kidney problems, and we also monitor the different ions or electrolytes in the blood and kidney function. And echinocandins are actually very safe with no monitoring required. And this is really just a schematic showing you the different resistance mechanisms that there are to these drugs, which I won't go into in detail, but is really just there for your reference. And this is the resistance in Aspergillus to azoles. So here you can see that, interestingly, some of these resistance mechanisms we see for resistance to the triazoles are caused by fungicide use in the environment. And we've published extensively on that. Then others can occur when you're on long-term treatment here. And this is the gene that the drug targets, called CYP51A. So despite this resistance, there are the new drugs that are becoming available. Abrexafungerp, which targets another part of the actually targets the cell wall as well, like the echinocandins. Fosmanogepix, opoconazole inhaled drug that we helped to develop, and then olorifim, another drug that targets the function of the mitochondria. So actually, there are drugs on the horizon that we can use that are currently in clinical trials, and hopefully will be successful. So I'll finish there, and thank you very much.
Thank you very much, Darius. That was absolutely fantastic. I learned so much then. I can't even begin to tell you. So much of what you said makes sense. We get so many questions from patients who have been taken off their treatment, or their treatment hasn't started and they don't understand why. And I think you just explained all that so eloquently. It was really good. Thank you so much. There are a lot of questions about treatment, so be prepared in the panel. So I would like to introduce our next speaker, who is a very dear friend of mine, Marcela Candies. She is going to talk to us about living with aspergillosis, so I'm sure that you will all find this fantastic. Marcela is a lawyer. She is a patient with aspergillosis. She lives in Portugal. How lucky is she? And she will be sharing her experiences of her diagnosis, her treatment, and also her tips for living with aspergillosis. Over to you, Marcela.
Thank you so much, Lisa. I'm trying to share my screen. I hope everybody can see it.
Not yet, Marcela.
No. And now?
Yes, we've got it. It's not on the big screen yet, though.
Now it's it. It is okay. I see. Do you can see it?
We can see your slides, but you're not sharing them as a
Okay.
presentation.
Okay. Let me try again. If it's not possible, I can ask the support. And now you can see?
Yes, we can. Thank you. Perfect.
Okay, thank you so much. I'm trying to, okay. Okay, I hope you can see all of them. Okay, thank you so much. Thank you so much of everybody, and thank you so much for the invitation and for the opportunity to share my story. I hope to help other patients with Aspergillosis and that my voice can spread to Portugal, raising awareness among people who have symptoms but have not yet been diagnosed. My name is Marcela Candeias. I'm a lawyer from Alentejo, Portugal. All of you know me, Liza and Tom. I share an office with my husband, who is also a lawyer. I had husband since 14 years old. It was always under control. Beside my husband, I work long hours, travel often, and I have no problem and any kind to think about my health. In 2020, everything changed. Well, speak about symptoms. When we start wearing protective masks, I start coughing constantly. No matter how many masks, different masks I try, the cough only become worse and worse. I was feeling exhausted and started to lose weight. The mucus I cough up changed color from green to black, and I began to have intense coughing fits. One of these fits lasted several hours. That was when I knew something was very, very wrong. During the breaks between COVID-19 lockdowns, I managed to see two pulmonologists. I was told it was just my husband and advised to continue with my regular medication, but the symptoms worsened. Well, I felt that no one was really listening to me. In 2022, I saw another pulmonologist who took my concern more seriously and ordered some tests, blood tests, and CT scan. A week later, the results showed that parts of my lungs were filled with consolidated mucus, and there was sign of bronchiectasis. Because of that, it was necessary doing a bronchoscopy. It is washing my lungs. In my case, the procedure revealed two types of fungi, Aspergillus fumigatus and Aspergillus niger, as well as bacteria in my lungs. I was diagnosed with ABPA, allergic bronchopulmonary aspergillosis. The photos, all you can see, they are taken by me. Well, living with aspergillosis, at the beginning I was scared. I was diagnosed with a rare disease. I had never even heard speak about that. The diagnosis turned my life upside down. Everything revolves around managing my condition. I have taken many courses of antibiotics and antifungals and experienced regular flares. I think three or four flares. The side effects of my medications are very difficult to deal with. I experienced tremors, swelling in my face, and lips, muscle and joint pain, difficult sleeping, depression, mental fog, mood swings, headaches, anxiety, and an overwhelming sense of exhaustion. My skin is often red and burns, as if I had been sunburned. Living with aspergillosis, the hard part is not just the symptoms, but the limitations that come with them. Since my diagnosis, I have had long periods when I could not work. I have had to give up traveling and many of activities once I loved. My whole life has had to be restructured around the illness. Every day is a challenge. Every day I try to do my best. Living with aspergillosis is living on a roller coaster. Each day is a challenge. Well, the emotional impact and effective. At first, it was very difficult to understand what disease I had and how to manage it. I had the support of my pulmonologist who saved my life and explained the challenge ahead of me. However, I was in panic. I had so much to do with the side effects of the medication, the constant medical tests and medical appointments. I was diagnosed in April 2022 and started taking the antifungal medication in May. In Portugal, we are entering in summer. It is my favorite season. I love the sun, the sea, the long days outdoors, and that summer was awful. I could only go outside fully covered up, wearing lots of sunscreens and hats. Out of kindness, the doctor let me go to the beach at 7 p.m. I fell in depression. I couldn't go to the restaurants because of the noise. I was always tired. I couldn't sleep. I had mood swings. An hour after taking the antifungal medication, I saw everything blue for half an hour. My friends and even my family didn't understand what illness I had. I felt anger, frustration, and a lot of sadness. I cried for days. I had to stop working. I couldn't protect my voice. I couldn't project my voice. As lawyer, it's very complicated. I lost my voice at the beginning. I could manage the stress and general fatigue. However, with a lot of sacrifice, I continued to practice yoga, pilates, and water aerobics, and take photos. From 2022 to 2024, I didn't work at all. This year, I only started working again in April, but always step by step. Here, I'm practicing yoga and pilates. I felt completely lost. I couldn't deal with the disease and the change it was causing in me and in my life. I felt like an earthquake had happened. To make matters worse, no one in Portugal knew about the disease, which means there was little empathy or understanding. I had to seek psychological and psychiatric help. So I started doing a lot of research by my own. That's because of that, the importance of support group or net group. The doctor who diagnosed me was a huge support. Unfortunately, awareness of aspergillosis in Portugal is very low. At the beginning, my husband and I felt completely alone. There was no support available locally, and we had to find our own way. I did a lot of research, and that is how I found the National Aspergillosis Center, NAC, in the UK. And because of that, everything I know about ABPA, I have learned through NET and the support group. I am so grateful to be a part of that group, and I feel enormous affections for everyone. I also found the Aspergillosis Trust support group, and they have become a daily source of comfort and friendship. Thank you, Liza. I had a meeting with Lisa from the trustees. Here my photo. After a wonderful conversation with her, I was invited to join the European Lung Foundation Health Patient Advisor Group. I felt it was a natural step and an opportunity to use my experience to support others for better awareness across Europe. I felt also it will be an opportunity to learn more about the disease in order to raise awareness among healthcare professionals and the general population in Portugal. Another photo. All these communities are now part of my extended family. They offer information and a sense of belonging. I am so grateful to belong to these groups. I feel that I'm not alone and that all my anxieties, fears, worries, and doubts are answered and support. They are my safe place. Well, practical tips for daily life. Keep a diary. I say all the time to make a diary, medication, side effects, symptoms, and so on. Be well informed about the disease and medication. Remember all the time, knowledge is power. Practice sport, walking, yoga, and meditation, everything you can do and enjoy and makes you comfortable. Take care of your diet. Rest when your body asks for it. Recognize your limit. It was very difficult to me. Find an hobby, like read, write, photos, painting, and everything. Accept that you have a chronic illness and that is not your fault. If you are working, find strategies for working and resting. Talk to someone about your anxieties, your fears. That is your support group. That's why you are very, very important for me. If your body has changed because the medication, find a new style of dress. If you cannot apply makeup because your hands are all the time shaking, stop using makeup or finding strategies to feel better. Your self-esteem is very, very important. Never, never lose hope. You are not alone. Practical tips, daily life. Here, me and my favorite beach. Every day brings challenge and lessons. My biggest challenge is finding a balance between my work, my personal life, and my illness. But I know I'm not alone. Thank you so much. I share my photos. Thank you.
Thank you very much, Marcella, for being so honest and forthcoming and telling your story of living with aspergillosis. As somebody who also lives with aspergillosis, I can identify with so much of what you said, particularly in relation to the side effects of medication. Every day is indeed a challenge, but there are positives and we have to remain positive, and you are certainly not alone. You tell a very powerful story, and thank you very much for that. It's probably worth mentioning at this point that your story, and indeed my own story and Lisa's and others, are on the European Lung Foundation website, as well as on the Aspergillosis Trust website. And I personally, again, have learned so much from reading the stories of people like Marcella and Lisa and others. So certainly people should log on there and get support. Thank you very much, Marcella.
Thank you so much.
So now we're moving on to the panel discussion and the questions and answers. And as Lisa alluded to, there are so many questions there. We need to move along, and I'm conscious of the time as well. So in the panel, joining Oksana, Mattia, Darius, and Marcella, we now welcome Graham Atherton for joining us. Graham leads the patient involvement and engagement for the National Aspergillosis Centre based in Manchester in the UK. Graham also coordinates the Community Awareness Research Education and Support Programme, which empowers patients and carers to take an active role in shaping research and service development for aspergillosis and related fungal diseases. So you're welcome to the panel, Graham. We'll also be hearing from Graham shortly after the panel discussion.
Thank you, Tom.
Okay. So there's lots of questions there, but I'll just kick off with one or two that had come in prior to today's session when people were registering. There's a question there, I suppose it's for everyone on the panel really, regarding food and ABPA. Are there any foods that can help reduce the symptoms of ABPA? And conversely, are there any foods that can exacerbate the symptoms? And a lot of people, when they think of fungi, they think of mushrooms, for instance. So something as simple as that. So maybe just throw that out to the panel, please. Who would like to come in on that?
I might.
Not.
Okay.
Go for it. Go for it, Mattia.
It's all yours.
Yeah, not that I'm aware of. I mean, I don't think that there's anything specific for ABPA.
Yeah, same for me. Yeah, I have never read any studies about that, but some of the patients actually sometimes tell me that they have more sputum when they drink about milky products or whatever. There's no studies about that, but yeah, so I cannot suggest anything about that.
Yeah, and it's probably worth knowing what you're sensitized to with your asthma as a broader kind of topic. And it's notable that some people, they have very high IgE levels, but they get told to have ABPA, but sometimes we find there's actually a more dominant other allergen that can explain their symptoms. So that's something important to be aware of.
I think what we hello.
Yes,
I think what we normally talk about is it's very easy to get bogged down, or very easy for patients to get bogged down in wondering the latest herbal medication supplement, the latest food, superfood is going to benefit them. And really, we would encourage people to stay away from that kind of thing. And the best way to stay healthy if you've got ABPA or CPA is to have a good balanced diet. Don't go for the exclusive diets. Just have a good balanced diet. You can get all the details of a good balanced diet on the NHS website. We highlight it a lot as well on our website on aspergillosis.org.
That's good advice there. Yeah. So another question that had come in there was, and I think Mattia mentioned it about the prevalence of Pseudomonas bacteria in infection in people who have aspergillosis. Could you maybe comment on that, Mattia?
Yeah, sure. So basically, what I said is that most of the ABPA patients and some of the CPA patients have bronchiectasis, and Pseudomonas is the most isolated pathogen in the airways of bronchiectasis people, so there's a good association between the two. And sometimes Pseudomonas might even resemble some of the radiological features of a BPA, for instance, decapitation or whatever. So there's a good overlap between the two. Sometimes it happens then that a patient with a non-diagnosis, so when we first perform the diagnosis, we perform a bronchoscopy and we find both Aspergillus and Pseudomonas. So it's pretty frequent. And sometimes it's even difficult to decide which bug to treat first, because they might have similar symptoms and similar manifestation of the disease. So basically, sometimes we just start with Pseudomonas because it's easy to target. A short course of antibiotics might actually improve the symptoms if Pseudomonas is dominant, but sometimes it's more difficult to decide which one is the most important driver of disease activity in a given moment. But yeah, it happens quite a lot.
Okay, thank you. Okay, Lisa, I'll go back to you there for some of the current questions.
Thank you, Tom. Yeah, we've got a lot of questions, and we had a lot of questions prior to today as well. So I'm trying to make sure that we cover as many of them as possible. One of the questions that's come up that's talks a little bit about what you were just talking about. So obviously we are aware that a lot of aspergillosis patients have an underlying disease, usually a chronic lung disease, cystic fibrosis, COPD, bronchiectasis, asthma. And somebody's asked the question, what could be the sign or the change in their daily symptoms that could warn them to check for aspergillosis with their doctor? So if we've got people looking in today who have a chronic lung condition, what should they be looking for, and what would make them go to the doctor to ask to be checked out for it?
I can try if it's possible. Very good questions, because a lot of patients have these questions. They don't know how to manage, especially when new symptoms appear. Changing in their daily symptoms with increase sputum volume, or changing in the color, or sometimes when the pulmonary function test, we have decrease of their volume. This, especially when we have patients with bronchiectasis, we can think about a new infections. But for chronic pulmonary aspergillosis, high-resolution CT will help us to identify one of these forms. And when we speak about ABPA in patients with asthma, as well, the appearance of bronchiectasis on high-resolution CT, but usually this will be more exacerbations and longer exacerbation, and no response to the treatment that they follow before.
Thank you. That's really good. Something else. Should aspergillosis patients have their immune status investigated? I know mine was, but is that something that you do routinely with all aspergillosis suspicions? You talk to us about diagnosis. Darius, do you want to answer that?
I can do this. So if you want, so basically, yes, we do assess the immune system of people, especially if they got an underlying respiratory condition. So in our clinic, all bronchiectasis people undergo a specific evaluation of the immune system, and this is something that we do when we detect the Aspergillus in the airways of these people. So basically, it's pretty common. The problem is that there are like different tests that you can perform. Some of them are actually blood tests and are easy to do. Some of them are quite complex. So when we got some issues, some clues that some additional tests might be required, we manage this in a multidisciplinary team with an immunologist, just to be sure that we're not missing anything.
Thank you. a question actually about the drugs. So as most azoles increase inhaled steroid dose in the blood, how do you differentiate between the effect of the antifungal versus the potent dose of an inhaled steroid in ABPA? It's quite a complicated question. Darius?
Should I take that one?
Please.
Yeah, I mean, I think that this is something that's variable between the different inhalers. I mean, the ones that have fluticasone in them are particularly a concern. We've done lots of analysis looking at it in terms of treatment outcomes, and probably there are independent effects for the azoles, obviously. So they do work outside of the inhalers. It is something that was used for a long time in the medical community to justify a hypothesis or a theory that antifungals didn't actually have any use for ABPA. And the reason that was being put forward by people who are experts in the area was because there was a belief that ABPA is not in any way an infection with the fungus, but simply exposure to allergy, to allergens of the fungus, i.e. proteins that are somehow just circulating in the air. And therefore, there's no way that an antifungal could work. So I think that the key point here is not sort of to be concerned that it's not the azole that's working, but rather the inhaler that's doing the treatment. But more to be aware that if you are on an inhaler and also an azole, and there might be a risk if that's fluticasone, that you could then develop suppression of your adrenal gland, which could lead you to not make any cortisol, which is a essential for life hormone. And so that needs to be very carefully looked at and monitored. And probably you should either be on less inhaler or in my view, a different inhaler if you're going to be on an azole.
Thank you, Darius. Yeah, we do have patients who have developed that adrenal insufficiency. We've got some of their stories on our website. Something that quite a lot of people are asking about is how do they find a specialist centre, and what should they be looking for in a specialist centre? You know, is there a particular type of doctor that they should be finding? Is there some sort of you know, a specialist team somewhere? Is there a list somewhere that patients can go to try to find the specialist in their area? There are there's a lot of people on this call today from 50 different countries represented, I think, and there are a lot of people who talk about the fact that they can't find a specialist or any care in their area. Can anybody answer that question?
I think it depends on the country. If I will speak about our country, we have a third level Institute of Pulmonology where we have a special team that look for this kind of patients, and we have a register for them and follow. And but we are 2.5 million population, not so many. We have a lot of aspergillosis, chronic pulmonary aspergillosis after TB sequela. Not so many with ABPA, but they can find at our institute the doctors and the suggestion for treatment and for the diagnosis.
Yeah, and just to say, in the UK, there's obviously the National Aspergillosis Centre, which is mainly around chronic pulmonary aspergillosis. And I think they do see other patients with ABPA. Invasive obviously is quite different because people are immunocompromised, and that kind of falls under a different part of the hospital. But there are other centres in the UK. We run one at the Brompton, and we don't have a specific list because at the moment what's happening is that there are some discussions about making more than one centre in the UK. So we hope to address that, but with the changes in NHS England, how quickly that's going to happen, whether it does actually happen, I don't know. So sorry about that. But we're trying to rectify that issue at the moment. So there are places nearby that people can go to.
Thank you, Darius. I knew it wasn't going to be an easy question to answer. It is something that we get asked about quite a lot.
We do get asked about it quite a lot as well, Lisa, and Darius is right. There's a few centres around UK you can go to, including Aberdeen, Edinburgh, Manchester, Liverpool, Newcastle, Cambridge, and London, in at least a couple of places in London. But abroad, if you want to look at the ECMM website, you've got the excellence centres scattered across the world that you can find contact details of on their website. And I think I wrote an article about this, which is on aspergillosis.org a few months ago, which I think spelled out a certain amount of this. Also, looking for a certain respiratory certain specialities. If you keep an eye out for those, that can be informative. If you're looking for respiratory specialists, infectious diseases specialists, cystic fibrosis specialists, you'll pick up people with the appropriate expertise in most countries across the world.
Thank you very much, Graham.
Lisa, may I?
Yes.
May I? Yes. Sorry to interrupt you. I think in Portugal it's very difficult to find a specialist. As I explained to you, I'm only at the first pneumologist we found the disease. My advice for all patients it is know everything about their symptoms and make research and be aware of the disease. After that, can ask to all the doctors the symptoms. Maybe because of that they can have a diagnosis or make the correct tests or CTs or blood tests. So if it's not possible find the correct doctor, maybe if you know a lot of the disease and the symptoms, can ask the correct answer. Thank you so much.
Thank you, Marcel. That's really good advice.
Lisa, maybe I just want to come in very quickly there and say that it's my opinion. I spent so long on antibiotics, from one antibiotic to another over many months, and I'm sure the medical people on the panel here will agree that all the antibiotics in the world will do nothing for aspergillosis. So my advice to people is to if you've had 2 and 3 different courses of antibiotic and then there's still no resolution to your symptoms, that you ask your GP, could this be fungal? Because not everything is bacterial or indeed viral, and that's my non-medical opinion, but it's from years of experience. So that's what I say to people.
It's also very good advice, Tom. Yes, thank you for that.
I mean, the other thing there is that anyone who's got severe asthma should be having allergy testing, basically, which should include Aspergillus. So, yeah.
Thank you.
Thank you.
We've run out of time for any more of our questions, and there are a lot, so I'm really sorry if you've asked a question and we haven't been able to answer it, but we will ask all our speakers today to look at the questions that have been asked, and we will ask them to answer them, and we will put up the answers on the ELF webpage, and we may also put it up on the NAC and the Aspergillosis Trust website as well. Now on to our final talk of the day. I'd like to invite Graham, who we have just met, obviously, in our Q&A session. As Tom explained before, he is Patient Involvement and Engagement Lead at the National Aspergillosis Centre based in Manchester in the UK. And Graham's going to talk to us today about how you can find information and support, and if you wish to get involved in raising awareness of aspergillosis. So thank you for joining us today, Graham, and over to you. Graham, you're on mute.
There we go. Can you see the slides?
Yes.
We can. Thank you.
Excellent. So we've heard an awful lot today, and I think it's emphasized how complex the mechanisms that cause aspergillosis are, consequently how complex it is to diagnose, how complex it is to even treat. Aspergillosis itself is a complex range of conditions. In fact, it's something of a misnomer to call ABPA a similar disease to CPA. These really should be treated quite separately. They just got the same name tagged onto them, which I think can be quite confusing. So what we've also heard is a lot from Marcella about how helping each other and helping patients who are very lonely, it's very difficult to get help, even in the UK sometimes. Across the world, it's even worse. So what I'm hoping we're trying to do in this initiative and the other initiatives we work out with the European Lung Foundation and the Aspergillosis Trust is we're getting together to try and make a difference. Now, we can make a difference in a number of ways. Oops, go back. One of those ways is advocacy for patients, raising awareness and driving real change. That's a big one. I've been involved in doing that for the National Aspergillosis Centre for a couple of decades probably, and we've got to this point, but there's still lots more to do. If you can get involved with the PAG, with the European Lung Foundation, all three of us are involved in that, and you can help us improve awareness across UK, across Europe, and maybe even further afield, hopefully making language less of a barrier. You can share your story, which we've found is very powerful. And we've had a couple of examples of that today. You can join our projects. This is one of those projects. We have other projects. I've got some I want to propose as well. But really, this is a patient-focused organization. It's led by patients, not really myself, who's working for the National Aspergillosis Centre. But we also have an interest in raising advocacy and just getting the critical mass of involvement up so we can make a difference to patients. There are patient networks and there are support groups. Aspergillosis Trust runs a large support group, and we run a large support group as well. You can get all of those, all that information on our website, which I'll talk about briefly in a minute. Information and support available to you, empowering patients, families and clinicians with knowledge and connections. It's not just about the patients, although the patients play a huge role in supporting each other. And even many times I've heard patients not pushing back, but suggesting to the professionals that they're involved with, maybe should we think about a fungus? Maybe should we think about using itraconazole if you go back 20 years? And that brings in, because the patient has focused on a group such as these and got information on groups such as these, not many medics do that kind of thing. It's an incredibly rare disease. They can't cover everything. So you taking your bit of knowledge and giving it to your local clinician can make a big difference. And working together, of course. We are one huge aspergillosis community, probably 2 or 3 at the moment, and we want to become one big community to give this whole effort a bigger emphasis. Okay, we've just been covering this. Aspergillosis patient journey is long and complex and is composed of many challenges. This is not something you should do on your own. It's something that you should join with us, join with the ELF, join with Aspergillosis Trust, and they can help guide you and give you emotional support at the very least. We've seen so many people coming to us after a long patient journey in which they've become depressed, as Marcella talked about. People get very anxious. People just don't think there's anything else out there. And once they've got that support, they feel much better, and much more able to cope with this long-term chronic disease. We ourselves, the NAC, run online meetings. Well, I'll make this available at this website. If you go to aspergillosis.org support meetings, that's our meetings, which are face-to-face. Marcella attends them. Lots of other people attend them. And that can be good for some people to help support. You can get lots of information, all the different types of groups that we run on this website, which I've just given you the URL for. Sorry, I'll go quite fast. I think we're running out of time. Facebook is a large active group. We've talked about that. We are not only in the NAC support groups, it's not only listening to people, us giving you information, it's you telling us information. And the way it's happening at the moment is you come up with the subject that you need information on, and we will go away and research that subject and put up an article on our website that addresses that subject, and also send it back to Facebook or wherever the question came from. So this can be very useful. We're doing it a lot, 5 to 10 new topics every week, and I'm developing this system which will make it easier to find. Lisa pointed out that it was actually hard to find these articles. So in response, taking me only 3 days, we've come up with this information hub idea. It's not finished, so we've not published it widely yet, but it is there and it is developing, and it's making it easier to find all kinds of every subject you can think of. And if you don't find that subject, tell us and we'll research that subject and advise, write another article accordingly. The Aspergillosis Trust, do you want to cover this, Lisa, or do you want me to carry on?
Carry on, you're doing a good job.
Want me to carry on? Okay. The Aspergillosis Trust is also another big community. This one, we are run by the NHS, and NAC is run by the NHS, and all the structure that involves impinges on that type of support. Aspergillosis Trust is entirely run by patients who impose their priorities and their needs on that group, which is slightly different to ours, but both together, I think we complement each other quite well. They do an awful lot of work promoting, and certainly if you could get involved in those groups, you would find a lot of support, and maybe even volunteer to help them do their important work as well. European Lung Foundation, which is where we are right now, has a broad range of projects around aspergillosis being developed. We've been developing mostly over the last maybe 2 years, 18 months, so we've got more to do. And the more people who get involved on our monthly online meetings, the more that we'll be able to achieve and hopefully do things quicker and better. This is the ELF has their own aspergillosis website, which has been mentioned a few times already today. I presume all of this information is going to be emailed to all participants of the meeting in due course. ELF have particularly run a really interesting program, which is a patient ambassador program. It's a free online self-learning program that will introduce you to some of the basic skills and knowledge needing to represent yourself and others successfully. It's more, I guess it's more of a formalized way of doing what we're all trying to do, which is promote well-being and reach out to other people who are in the same situation, which is what Marcella's trying to do, so they don't live through the same problems that you lived through. And in that way, we can have hundreds and thousands of advocates who can find all those patients, and there are a lot of patients that have not been diagnosed yet, who have the different types of aspergillosis. We need to find them, we need to contact them, we need to pull them in, and we need to support them. So there you are. I think that's the end of the slides. These are the contact details and the main ways of getting to the information from all three organisations. The National Aspergillosis Centre, just because I know most about that. Also, its main information website for patients is at aspergillosis.org, rather than that the MFT NHS website, which is the NHS Access. And that's it. Thank you very much for listening.
Thank you, Graham. That was great, and I think it's just to reinforce it is so important that if you are a patient out there and you are struggling, that you contact one of us, reach out to one of those groups or all of those groups. There is support and help for you. And Graham mentioned about just little things that you can do within your own community. Share information with your own doctor's surgeries. That's something that the Aspergillosis Trust has been doing recently, certainly in my local area. And there are patient leaflets on the Aspergillosis Trust website. So if you are looking for leaflets, there are specific, there's a general Aspergillosis patient leaflet, and then there is also more detailed ones specific to the individual conditions. They're available for you to download in PDF form in 30 different languages. So hopefully you will be able to find that leaflet in your language. If you can't, please contact us and we'll see what we can do. Okay, so sadly that was our last talk of the day. I would like to invite all our participants to take a poll. If we can get that poll up there again, please. So it should be there for you now. So if I could invite you all just to please vote on what your knowledge is after today's session compared to what you knew beforehand. Okay. Wow. Wow. What a fantastic improvement. That's brilliant. I don't think we had anybody at 10 before, and we now have 21%, 27, so almost more than 70% of you at the top end of the scale, which is fantastic. I think that proves that webinars like today are really, really valuable for us learning about this condition and these diseases. Over to you, Tom.
Yeah, thank you very much, Lisa. And this is a lot of thank yous. I want to thank all of the speakers and the contributors today, and indeed all the people who put in questions and comments in the chat line as well. It's all appreciated. I want to thank my friends in the patient advisory group of the Aspergillosis in the Lung Foundation and everyone who helped promote today's event. I want to thank everyone who joined online. It's wonderful to know that people from over 50 countries across the world have joined us today at some point during the conference. So that's super. I know that I've certainly learned a lot today, and indeed I'm sure everybody that joined has also learned. On a personal level, I want to thank Lisa for being a supporting co-chair to me. I'm pretty new to this game. I only joined the Lung Foundation earlier this year. So thank you, Lisa, for being a support. I also want to thank Graham and the team in the NAC. They've been a huge support to me since I was diagnosed with this disease. I also want to thank Ellie and the team in the Lung Foundation, the European Lung Foundation, for making this day happen. A lot of work has gone into this event over many weeks by Ellie and her team, and great credit is due to her. She's not front of screen today, but she's in the background working away. So thank you. That's all I have to say for now, anyway. And it's been a pleasure to co-chair the event with Lisa. I certainly look forward to future involvement, and thank you.
Thank you, Tom. Thank you for your help as well. It just sits with me to. I hope you've enjoyed our first Aspergillosis patient conference. I hope that you found it helpful. I hope you've learned a lot. I know that I have. The whole webinar has been recorded, and the ELF will hope to have that on their website soon, usually within 2 to 3 weeks. So I think we just need to say goodbye. Thank you so much.
Thank you.
Thank you so much. Thank you so much.
Bye, everyone.
Thank you so much. Thank you. Bye.
Bye.
Bye. Bye.